So good evening, everyone, and welcome to the ski webinar. We are live now.
Good evening, everyone. Thank you so much for joining in. This webinar is a short refresher course, you can say, on high tibial osteotomy. We have 4 very crisp talks given by 4 eminent speakers, followed by a panel discussion. And the general housekeeping rules are, after each talk, we will be able to take 1 or 2 very quick questions. I would request you to please type in your questions in the chat box and we'll try our best to take them. I will request the speakers to try to see if they can answer the questions live in the chat box to the best of their abilities. So without further ado, let us start this program. We'll start with the welcome address from our president, Dr. Ashok Rajgopal.
It is with great pleasure that I congratulate SKI, Dr. Parag Sancheti, Dr. Ashok, Dr. Raju, Easwaran, Vikas, Khanduja, Dinshaw Pardiwala, and the speakers on this wonderful topic and debate that is going to ensue over the next few minutes. I'm sorry I'm not able to be present in person. I have some prior commitments. But I think this is a fascinating topic and particularly lends credence to the fact that there is a lot more to knee surgery than arthroscopy and joint replacements. Of late, osteotomies have taken on their own dimension and they form a very prominent part of the armamentarium of the knee surgeon in joint conservation, particularly in the young arthritic patient or the patient with a malaligned angular deformity of the knee. We have a wonderful panel of speakers, and I am confident and I'm sure that there'll be a very extensive and animated debate on the topics, and I would encourage all the participants to actively engage themselves and ask questions. I wish this meeting every success, and I'm sure all of us who are attending will go back richer for the experience of having listened to these wonderful speakers. Thank you and have a wonderful evening and stay safe. God bless.
Thank you very much, sir. With this introduction, I'd like to request our Joint Secretary, Dr. Parag Sancheti, to give an introduction to this course. Over to you, Dr. Parag.
Thank you very much, Raju. Good evening to all the viewers from India. Good afternoon to the viewers from UK, and good morning to the viewers from South America. It's indeed a great pleasure to have today to discuss knee joint preservation, getting high on high tibial osteotomy. It's indeed a very hot topic, and we have an excellent faculty to talk to us today on high tibial osteotomy. We have Dr. Raghbir Khakha. Needs no introduction. He's from UK, and the rest of the speakers are our own SKI founder members. Dr. Sachin Tapasvi, the secretary, Dr. Dinshaw Pardiwala, Dr. Vikas Khanduja from UK, who also has a lot of passion for this topic, knee preservation, Dr. Bhushan, Sabnis, Dr. Pankaj Walecha, and this webinar is going to be conducted by Dr. Raju Easwaran. He has been putting all this together for the last few weeks, and today we will see the culmination of his efforts. I don't want to be long between you and the speakers, but all I can say is that high tibial osteotomy is somehow becoming a lost art. Probably the unicondylar is slightly scoring over it. The open wedge is the way to go. And we talk of high tibial osteotomies in situations like an ACL reconstruction and other such slope modifying osteotomies. So to tell us today about all this and to convince us why an high tibial osteotomy should not be an forgotten art, we are going to hear all the stalwarts today, and I'm really looking forward to their talks. Without further ado, welcome all the faculty, welcome all the SKI founder members, and most of all the delegates who have joined in. Currently, I can see about 860 people who are live viewing us. So welcome all of you, and over to Dr. Raju to take further the session on getting high on high tibial osteotomy. Thank you.
Thank you so much, Dr. Parag. So we begin our scientific session, Alan Lakin famously said that failing to plan is planning to fail. And therefore, very aptly, the very first talk that we have is how to best plan a high tibial osteotomy. We also have a little bit on how to plan the distal femoral osteotomy and a double level osteotomy. I now invite Dr. Raghbir Khakha from the London Osteotomy Clinic to start his talk.
Surgeon based out of Guy's and St Thomas's in London. And I've been asked to speak to you today how I plan a high tibial, distal femoral and double level osteotomy. I'm also part of the orthopedic specialist group in London, and my subspecialist interest is in knee osteoarthritis and sports injuries. My passion for joint preservation surgery is well known, and I'm here to speak to you today how I plan these operations. I'm really involved with education, so you can see a lot of our videos on how to perform these procedures on our YouTube channel together with Professor Adrian Wilson. If you just simply type in orthopedic specialist, you'll come across our page. So it's really important to get the right x-rays for your long leg alignment view. Make sure that the camera is at the level of the knee, so you get an appropriate image and there's no obliquity, and you need to be at a defined distance. It's important to engage with the radiographers to make sure that when they take the pictures for the patient, that the patella is pointing straight ahead, and this may occasionally require internal rotation of the lower limb. So the patella must point straight ahead. The pelvic tilt is equally important. You can see here that due to a shortened limb, there's pelvic obliquity. So you need to put a step underneath the foot to get this equal. And you can see that it can give you very different images if you don't do that. It's really important to recognize that actually the dogma of varus osteoarthritis arising from the tibia and valgus arising from the femur doesn't always hold true. So you can see from these images that actually even in a varus deformity, you might have the deformity in the femur, and likewise in the valgus alignment, you might have it in the tibia. So it is important to do deformity analysis. So I'm going to do a quick review on how I do my osteotomy planning. We're starting with the tibia, but the principles are applicable to the femur also. This is the Miniati method. So we take a line from the center of the femoral head and draw it straight down to the middle of the ankle joint. Now this gives us our mechanical axis. We then draw a line to the point where we wish the ankle to end up, bisecting through the tibial plateau at a point that's normally 55% of the width of the plateau, where we want our correction to end up. We define the hinge point for the osteotomy, and that's typically at the level of the fibular head. And from that hinge point, we draw a line A to where the current center of the ankle is, and down to line B, where we wish for the ankle center to end up. This then gives us an angle between line A and line B, and we reflect this angle in the proximal tibia to give us the amount of opening that we require. And based on a calibrated film, we're able to measure the distance that we need to open at the time of surgery. It's really important that not all corrections are done at the level that we anticipate. For example, in this, you would expect to do a correction just at the tibia because of the mechanical axis going through the missing the joint on the medial side. However, if we just did this all in the tibia, you can see it's a massive correction, and you end up with quite a significant MPTA. But not only that, you end up with a huge joint line obliquity. So in this instance, it's important to share it amongst the two bones in performing a double level osteotomy to maintain a horizontal joint line. I'll now demonstrate how I do that. So we'll first plan our high tibial osteotomy. This is our long leg alignment view with a calibration ball at 25.4 millimeters. Once we've marked this out, we start marking out our typical parameters, including the proximal hip, distal femur, proximal tibia, and distal tibia. Once we've marked these out, we need to tell the computer the joint centers, and this is what we've done here in the proximal, in the hip joint, in the center of the femoral head. We will define our distal femoral angle, our proximal tibial angle, and our distal tibial angle also. The markers here demonstrate the mechanical medial proximal tibial angle is the only changed variable here, and the mechanical axis is going through the medial compartment of the knee. Once we've identified the center of the tibia, we then mark out our hinge point. Our hinge point is typically at the level of the fibular head, 7 millimeters away from the edge of the lateral cortex, and you can see my entry point is nicely in metaphyseal bone with enough proximal space to put in a locking plate. I then need to find out the width of the tibial plateau, and my correction point is typically 55% of the whole width of the tibial plateau, and that's the point that I wish to correct to. Once I've marked this out, I'm now happy that my osteotomy position is correct, and I can simulate the osteotomy by finishing and cutting the long leg alignment and splitting it into a proximal and distal segment. I then fine-tune at my hinge point up to the point of my correction at 55% of the tibial plateau. As I do this, you will be able to see the figures on the left demonstrating the MPTA has now gone to a normal figure of 90, and the opening that is required is 10.3 millimeters. Moving on to the DFO, we've already pre-marked our hip center, and this patient's got a valgus alignment with mechanical axis going through the lateral compartment of the knee. We then identify that the LDFA is reduced at 84 degrees, so the correction needs to occur in the femur. We make the landmarks of the femoral segment, and then we define our hinge point. I prefer to do a medial closing wedge femoral osteotomy, and I've defined my hinge point once again 7 millimeters from the lateral cortex, and my entry point in nice metaphyseal bone. As I did for the tibial osteotomy, I mark out the width of the tibial plateau, and for my correction, I like to go into the medial compartment at approximately 45%. Now you can go anywhere between 45 and 50%. Different papers will show different values, but you can see how I've done the calculation of where I want to correct to. I now tell the computer the segments, and once this is done, I can simulate my closing wedge osteotomy up to the point of where I wish my correction to be. And as you can see from the final adjustment and fine tuning, we are able to simulate a closing osteotomy of 4.4 millimeters with normal lateral distal femoral angle without creating a secondary deformity. I can then write a report, and this is useful for me when it comes to going into theatre and performing the actual osteotomy. We're next going to plan a double level osteotomy. Here you can see a patient with severe varus on the left-hand side, and I've already taken the liberty of marking out the landmarks and calibrating the X-ray. And in the column you can see that the LDFA and MPTA are both deranged, and the mechanical axis is missing the joint line. So we define the tibia in the usual fashion, and mark our hinge point at the top of the fibular head and the entry point of the osteotomy in metaphyseal bone, giving us enough space to put a locking plate above it. And we have to do the same with the femur. Given that the abnormality is in both bones, we've identified that this patient will require a double level osteotomy. The hinge point is in the typical position of approximately 7 millimeters away from the medial cortex, and in this instance we're doing a lateral distal femoral closing wedge osteotomy. This patient also has a raised JLCA, and we're going to reduce this down to a normal value so that we do not over correct this patient. If we have a very large JLCA, for example, if it was something like 8 degrees, to reduce the standard deviation to within a normal limit, the formula that we use is JLCA minus 2 divided by 2. So now we've identified the 3 separate segments, the femur, the tibia, as well as the joint. We're now defining where we would like to take our osteotomy correction to by marking out the width of the tibial plateau. And this is a varus knee, and we would like to go to 55% of the width of the tibial plateau across the lateral side. Once we've identified all our landmarks, we can then separate the separate fragments and start to adjust our fragments so that we can go to normal values of MPTA, LDFA, and reduce the JLCA. So as you can see, I've done a very small correction in the joint itself to account for the soft tissue laxity. I'm now going to work on the tibial osteotomy and femoral osteotomy, fine tuning so that our figures stay within normal limits. And at the moment, you can see here it's at 90 degrees, and I've still got quite a lot of correction to perform. So I correct at the level of the femur, and I watch my figures in the column on the left-hand side to see the LDFA, and fine-tune on both sides so that I stay within normal limits. As you can see, the figures are nicely corrected. I've reached my 55%. I'm very happy with this correction. So I can then execute this procedure in theatre and write a report in the usual fashion. Thank you for listening to this talk. Look forward to going through this with you in greater detail in the question and answers. Thank you.
Thanks, Raghbir. Vikas, you had a question to ask?
Yeah, just a quick question, Rags. That's an excellent demonstration of how you actually plan your osteotomy. But let's say I don't have these fancy tools, and you're dealing with 1.7 degrees and 3 millimeters and 5 millimeters, which is obviously very important to get that accurate correction. How do you go about that? So,
yeah, sorry,
yeah, go ahead. Yeah, go ahead. So if you don't have these fancy planning tools, how do we do it?
Yeah, so there are ways, that you can say by changing a degree, that you might get a millimeter of correction, and there used to be these formulas that we used, but they can be incredibly inaccurate to do that. So a good old-fashioned pen and paper, doing the Miniachi method is definitely doable. So just by simply doing the first diagram that I showed you, drawing your mechanical axis, defining where you want to end up, and once you've got your angle from your hinge point and you can translate onto the tibia, it just takes a little bit longer, but you can do it. Now, anybody who's doing that technique, I think it's really important that you double check everything in theatre. So having an alignment rod available is vitally important. An X-ray to be able to see the center of the hip and the center of the ankle through a radiolucent table. So, I mean, I routinely still double check my osteotomies, even though I've planned them using, calibrated X-rays. But if you're going to do it on pen and paper, work out the angles and translate them to a measurement on the tibia, you must check them in theatre as well.
So basically, not having the software does not obviate the need of doing an osteotomy. You can still do it as long as you are doing it on pen and paper.
Without a shadow of a doubt, that's how we've been doing it for decades. And, these are just sort of new tools that we're sort of have in our toolbox. But anybody who's starting out, I would advocate doing it on pen and paper first.
Thanks, Rags.
Raghbir, one question that I have, does this software accept images taken from a mobile phone? Because that is sometimes the most common input that we have to give orthopedic softwares.
Yeah, it does. So as long as you know what the calibration is on that image that's been sent to you, then you can upload it. These softwares typically accept any JPEG or .png type images, so you can upload them. As long as you have got something to demonstrate what the actual calibration is, you can use them.
Right. So if your X-ray has a calibration marker, you can click a picture from your mobile phone, your resident can send it, and you can still do the planning. Is that correct?
You can still do it. Yeah. It's obviously not as perfect, but it works. I've like you, so we get patients from around the world traveling in for their procedures, and we just simply do it off the images they give us from their phones.
And another question, Raghbir, is that the value that you get from these digital planning software, say you got an opening of 4 millimeter. Now, when you do that surgery, where does that 4 millimeter generally fit in? Is it the posterior osteotomy gap or the anterior gap or somewhere in the middle?
Oh, it's a fantastic question, Raju. And particularly with the opening osteotomies, you've got to put it at the back. The problem is that you can alter your slope if you're going at the front. The medial side of the tibia is trapezoidal. So you're measuring at the back of the tibia so that you do not then end up increasing your slope. So the key message, as you say, make sure you measure off the back.
Right. So the measures that you get, for the sake of repetition, whatever measure you get from these planning softwares or the Miniachi method is the posterior gap.
Yeah, just one more point to add. We are so precise about this. So with the method, the opening that we measure, we add on 1.2 millimeters for the saw blade thickness. So whatever saw blade you use, make sure you know the thickness for that and add it onto your correction.
Any other questions are there in the chat box? But one key message, Raghbir, that I got from your talk is that the stereotypical thinking that varus is due to the tibial deformity and a valgus is necessarily due to a femoral deformity must be dispensed away with. What is your one simple tip? How can we smell a double level osteotomy on a long leg X-ray just by seeing the Michaelis line?
So the minute it misses the joint, you've got to be thinking, the minute it misses either the medial compartment or lateral compartment, please think double level.
So I feel that is perhaps the most key message, because a lot of us may be in the false hope that we can just do a simple HTO and correct any kind of a varus deformity, which may actually not be true. Right. So if there are any more questions for you, Raghbir, we will of course come again.
Sachin had a question.
Oh, yes.
So, Rag's great talk as always. A quick comment from your side as regards preoperative planning. You discussed the miniature method. Is there a comment that you would like to make vis-a-vis the miniature method and the Dugdale noise method?
Yeah, I mean, to be honest, I've not really had much experience with the Dugdale noise method. I've only ever sort of grown up on the Miniachi method. But from my reading of the texts, I think they're equally valid in their approaches. Whatever you're most comfortable with, and whatever you do more routinely, you shouldn't sort of change. But whatever you're comfortable with, Sachin.
Okay.
Right. So thank you so much. And if there are no further questions, we'll move on for now. I think for most of us knee surgeons, ACL surgery would probably be the commonest procedure that we would end up doing. And the next talk is going to address how to simultaneously do a HTO with an ACL, when to do it, and how to technically execute it. The next talk by Dr. Dinshaw Pardiwala.
All of you online again. I'm going to take single stage ACL reconstruction with medial opening wedge high tibial osteotomy, the indications and technique. When you treat a chronic ACL deficient knee with medial unicompartmental OA, you should opt for a single stage ACL reconstruction with medial opening wedge HTO if the patient has instability, pain, and varus malalignment. The indication for this procedure is if all three of these factors are present. So if there's no instability and only pain with varus malalignment, I would perform just an HTO. And conversely, if there was only instability and no malalignment, I would rather do just an arthroscopic ACL reconstruction. Although the techniques for ACL reconstruction and medial opening wedge HTO are fairly standardized, the critical aspect of this surgery involves ensuring that the ACL tibial tunnel does not interfere with the proximal screws used for HTO fixation. And the following technique will demonstrate this important aspect of the operation. This is a young male who has a chronic ACL deficient knee with varus malalignment and medial compartment pain. The correction is planned on a pre-op scanogram as just described in the previous lecture. Although MRI may suggest that the lateral compartment is normal, it is important to confirm this on diagnostic arthroscopy. It's important to confirm that both the lateral meniscus and the articular cartilage are normal. The medial meniscus and medial compartment is then checked. Any unstable medial meniscus tear needs to be excised. Any chondral flaps also need to be shaved and stabilized. You may opt to perform a chondroplasty or a bone marrow stimulation for grade 4 chondral defects. A notchplasty and osteophyte excision is often necessary in these chronic ACL deficient knees. After that, I would harvest the hamstrings, prepare them, size them, and then go ahead for my femoral tunnel. So the femoral tunnel is prepared in hyperflexion of the knee, and then I'd go for my tibial tunnel. Hamstring autografts fixed with suspensory fixation make this procedure simpler, and I would recommend that as the graft and fixation of choice for these combined procedures. Once the ACL tunnels are created, we proceed for the medial opening wedge HTO. During the exposure, the patellar tendon with tibial tuberosity needs to be identified for the biplane osteotomy. Also, the anterior aspect of the superficial MCL needs to be released. I typically then place 2 or 3 radio-opaque gauze pieces posteriorly to push the soft tissues away from the bone and protect the neurovascular bundle. Alternatively, you could use a radio-opaque Hohmann's retractor too. A guide wire is then passed to mark the osteotomy cut. Note that this is a bit inferior to the usual metaphyseal site of the guide wire to ensure that the entire ACL tibial tunnel is within the proximal fragment. A second parallel guide wire is then inserted in plane with the posterior tibial slope. Now the biplane osteotomy is performed. I take the anterior cut first at 110 degrees to the transverse cut. And then I take, under C-arm control, the transverse cut. This extends right up to the hinge point, which is 10 to 15 millimeters from the lateral cortex. I then insert a flat osteotome to this level. Osteotomes are then inserted to achieve controlled opening of the osteotomy at the hinge. I then insert the laminar spreader and open it to the calculated wedge size. Typically, I will get an MPTA of 90 degrees at this step. After this, I perform an intra-op check of the mechanical axis and ensure that this passes through the lateral tibial spine. And then proceed with plate positioning. To ensure that the proximal screws do not interfere with my ACL tibial tunnel, I place a reamer within the tibial tunnel and then go ahead with fixation. Besides 4 monoaxial locking holes, this special plate has 2 polyaxial locking holes in the proximal part on either side of the ACL tunnel to avoid damaging the graft. The anterior-most screw goes anterior to the tunnel and avoids the reamer, whereas the central polyaxial screw is aimed posterior to the reamer. Once fixation of the HTO is complete, this is what it would look like. The graft is now passed and then fixed. I always use a hamstring tendon autograft and fix with a femoral suspensory fixation after cyclical tensioning. So I've locked the graft there. And now on the tibial side, I'll go ahead with the fixation. This typically is done with either a suture disc or a bioscrew. And finally, I'll graft the osteotomy site with allograft bone. This is what the 2-month X-ray would typically look like. There are 2 common questions asked. The first is, which HTO implant should be used, and whether you need a special plate like the one I just demonstrated, or whether it can be done with other plates too. Well, combined ACL reconstruction with HTO has been performed since over 25 years with the fixation devices popular at that time. I've always used the same sequence and technique as I just demonstrated, but the newer specialized plates, it's simpler and more predictable to get a good osteotomy and at the same time not compromise on the results of the ACL reconstruction. In this patient of 2001, you can see that I had to adjust the anterior screw of the plate to go posteriorly to accommodate the tibial tunnel, and this may compromise the HTO fixation. On the other hand, in this patient, I've had to adjust the tibial tunnel of the ACL a bit posteriorly to ensure that I have adequate space anteriorly for a screw, and this may actually compromise the ACL. I have used many of the other plates available, but find that the metaphyseal aspect of these plates is too large to accommodate both a biplanar osteotomy and an ACL tibial tunnel, and so find that these newer special plates are ideal for this combination surgery. The second question is that of the posterior tibial slope. We know that decreasing tibial slope decreases anterior tibial translation and protects the ACL graft. However, I don't routinely alter the slope during this combined surgery. I only do a slope correction in ACLs for failed ACL reconstruction with increased posterior tibial slope. Finally, what are the expected outcomes? Numerous studies have shown excellent survivorship up to 15 years, but a recent meta-analysis revealed a 17.5% ACL graft failure rate, with 6.5% of patients requiring a revision HTO. Moreover, patients continue to show progression of OA despite HTO, although this may be at a slower rate. Thank you.
Thank you very much, Dinshaw. That was an excellent talk. I have two quick questions for you, Dinshaw. In the X-ray that you showed, you obviously did the osteotomy and ACL on one side, but it was a bilateral symmetrical varus. Now, in long-term follow-ups, do these patients crib because nature doesn't tolerate asymmetry that well?
I think basically nature tolerates asymmetry up to about a centimeter. I think so up to a centimeter, most patients don't feel a significant difference. Typically when these patients are coming in, they're coming in for ACL instability with a varus, and you'll find that the opposite side may not necessarily have the same varus. So when you've done an opening wedge osteotomy, you've lengthened them a little bit and this equalizes them to a large extent. I think the problem primarily occurs in patients who've got bilateral OA and who've got a varus. And these patients, when you correct, typically you're going to correct the other side also. So in case they do feel some symptoms, it's only in the interim period between the two osteotomies. But typically you will get them to almost same length once both osteotomies are done.
Dr. Maheshwari, you had a question?
Yeah, Dinshaw, my sequence is just the reverse. So I do a high tibial osteotomy first, and then my usual ACL reconstruction later. And I'm just not bothered about the tibia part because osteotomy has been done. I do find when I'm drilling my tibial tunnel, one of the screw comes in my way, you know, usually the anterior one or sometimes the middle one, and I just remove that screw and that's it. So what is your objection to this?
You remove the screw and then put another screw there?
No, nothing. So I leave, instead of 4, there are 3 now. So I use Tomofix. So instead of 4, there are 3 there. And that seems to make it simple because you do a STO, now it's like another ACL reconstruction for you.
True. If that works in your hands, I think no problem with that. But typically what happens is when you're doing the arthroscopy and you're doing the ACL, you're going to put this patient into hyperflexion for the femoral tunnel. You're going to do some sort of meniscal work. So the knee is going to be put into varus and valgus and figure of 4. And typically you don't want to do that once you've done your fixation for the osteotomy. You know, put all these forces on the distal fragment, which has just been fixed with the opening wedge osteotomy and with the hinge there. So therefore, I would rather finish off the ACL tunnel first, exactly as I showed. The only thing that you need to be careful about is make sure that when you're fixing it, your screws don't come in the way of the tunnel. So therefore, the simple trick of putting a reamer in there, and if you've got polyaxial screws, you can avoid that very easily. And you could do the same thing even without this special plate. And we used to do that in the past, but you had a little more difficulty because of, there's a limit to how much you can change the angle in the standard plates.
So you think removing one central screw, you're compromising quite a bit? Because I like this Tomofix, which is a sturdy plate. And you can, I don't worry much about bending the knee, over bending. It looks very, very solid fixation. In fact, I make them weight bear next morning, more or less.
True. I think the Tomofix was meant for that. It's meant basically so that you can start off early weight bearing. But I'm not so sure what happens if you do take out one screw. I'm not aware of any studies which have showed whether taking out one of the screws from the upper level is going to make a difference in the strength and the rigidity of the construct.
Okay.
Dr. Parag, you had a comment?
Yeah, I just had 2 quick questions. Do we have the time, Raju?
Yeah, most certainly. Please go ahead.
Very quickly. So first question, Dinshaw, excellent talk like always, is about the biplanar osteotomy. Whenever, I usually do a biplanar osteotomy if it's like for a osteoarthritic knee, but in case of ACL, my experience has not been very good while doing a biplanar, and I've stopped doing that. Do you have any thoughts on whether if it's a combined procedure with a ACL reconstruction, whether to do or whether not to do? Do you have any suggestions, or do you think my thinking of not doing a biplanar is not the appropriate one in the current times.
Okay, so I think you've got advantages and disadvantages for both. When you're doing a monoplanar osteotomy is of course much simpler, and you've got more metaphyseal bone to take your ACL tunnel. So you could shift your ACL tunnel anteriorly. So that's the advantage, and that's probably why you're doing a monoplanar. But at least for me, I would say 99% of the times with the varus that I'm dealing with, I would need to do a biplanar osteotomy because the level is going to be lower. So typically when I'm doing it, I'm going to do a biplanar osteotomy. My level of the transverse cut is going to be lower because I'm trying to get the entire ACL tunnel in the proximal fragment. Now, as soon as my level of the osteotomy is even 10 millimeters lower, I would go right through the tibial tuberosity, and I'm going to create a problem for the extensor apparatus if I don't do a biplanar. So that's why I think for me, the advantage is do a biplanar. The disadvantage of the biplanar is that you probably require a special plate if you want the ideal scenario, because now you've got a plate there, you've got a tunnel there, and then you've got the biplanar cut of that biplanar osteotomy. So if your tibia metaphysis is not that large to accommodate all three, become a problem.
Exactly.
Now the second thing that would happen is if you're doing a uniplanar osteotomy, it's not biplanar, then your tunnel, your ACL tunnel is probably going to come at the level of the osteotomy, or in fact go across it. So that also may be a little bit of a concern, because your graft will then be at the level of the osteotomy, at the opening of that osteotomy. So your fixation may be a bit compromised. But I think, again, in all of these, you just need to be comfortable with the technique that you're doing. And if you're doing what you're doing, getting the mechanical axis correct at the end of the day, getting a good, strong, taut ACL fixed well at the end of the day, you can modify your rehab and get the ideal outcome, for that patient.
Okay,
We have
thanks.
last closing comments from Raghbir and Bhushan after Parag's next question.
Yeah.
Yeah, sorry, just a really quick comment. I thought it was a brilliant question by Dr. Parag, that people ask that all the time. And, I do the same method as Dinshaw, word for word, step by step. But some people go distal biplane if they're worried about having not enough proximal bone. So it's a little bit trickier, a slightly bigger exposure. But if there's any concerns about where your osteotomy level is, and if you've got enough bone for the biplane, you can do a distal biplane. That's one other get out of jail card.
Yeah, Dinshaw.
Raghbir, that's a great trick out there. Now tell me, between the proximal biplane and the distal biplanar, the proximal biplanar is in good metaphyseal bone, and I believe that these actually unite by around the third week or so. Is that the same with the distal biplanar? Do you think that the mechanics should be a little different? It might take a little longer because you're now almost into diaphyseal bone?
Almost certainly it takes a little longer. And I reserve my distal biplanes for corrections greater than 12 millimeters because of the adjustment of the patella height. So I only do it in that instance. I don't routinely do distal biplane. But you're completely right. Your rehab then has to change a little bit. It does take that much longer. So the distal biplane, you need at least 2, usually 3 good small fragment compression screws. 2, I normally manage to get 2 because there's not that much space. So yeah, your weight bearing status will change a little bit, and the rehab takes longer.
Thank you very much. That clears my doubts. Raju, I'll take the second question later on during the general discussion. We can just have quick comments from Bhushan and Pankaj.
Yeah, please.
So exactly the same point as Rags made. So I'm always worried about my tibial tunnel falling in the proximal biplane, and that makes it a disaster when you're just finishing the surgery, when you realize that your tunnel is coming bang in the proximal biplane. So I generally go for a distal biplane, Dinshaw. As you rightly said, it is diaphyseal, it takes longer, but if you're done a compression screw fixation to the distal biplane, it might give it a good stability as well. And all of these patients will have some component of patellar early arthritis as well. So they are better off when you're not creating a patella baha, especially if your correction is more than 10 millimeters. So I worked with Rags before. Our cutoff point was 12.5. So I think that's the only comment I want to make. Thanks.
Pankaj?
I just wanted to say that when we are doing an osteotomy, which is more distal than usual, and when we are doing a distal tibial tubercle osteotomy, we have to keep that fragment long enough to at least have 2 screws there. I mean, because we are lower and then we need to keep it relatively longer than usual.
Right. So I think we'll finish the discussion here. And just one comment that I wanted to make in addition was maybe this particular surgery, ACL plus HTO, is ideally suited for an all-inside ACL, wherein you actually don't end up drilling anything in the tibial cortex. Maybe that's food for thought. We'll now move on to the next talk by Dr. Pankaj Walecha, and he'll be speaking to us on the complications of high tibial osteotomy.
Weight bearing to the desired point. Adequate correction is the key to success, and we must assess our correction using an alignment rod and not a cautery cord. You should also ensure that your patella is in the center of the knee when you're making this assessment.
Can you please play from the start? I think it's played from the center.
If we do an osteotomy which is shorter than planned, that shifts your hinge point medially, and that can lead to undercorrection. Let's understand how. In these three triangles, this yellow dot is the hinge point and the red line is the osteotomy line. In all the three situations, we are trying to do a correction of 20 degrees. But if my osteotomy gets shorter, which means my hinge point shifts medially, in that case, my height of the osteotomy, which I'm going to open, is decreasing. So if my hinge point is medial or if my osteotomy is short, I'm going to do an undercorrection. It can also happen if you do your osteotomy up to the pre-planned hinge point, but your osteotomy spreader does not reach that hinge point. In such a case, as you can see here in the first picture, the spreader has gone up to 50 millimeter mark. In the second, up to 30 millimeter. Doing a correction of 9 degrees in both the models. But when we measure the osteotomy opening, it is 11 millimeters in the first picture and 7 millimeters in the second picture, clearly leading to undercorrection. So the takeaways are that we should do our osteotomy up to the planned hinge point, and not only the angle of correction, rather we should also know the height of the osteotomy in the pre-op planning. Concomitant ligamentous laxity should always be considered and should be subtracted from the angle of correction to prevent overcorrection. Because if we do overcorrection, that will not only lead to joint line obliquity, but as Dugdale Noyes said, that if we correct the soft tissue component in the bone, that will lead to overloading of the lateral compartment, and that will lead to early failure of the osteotomy. Also remember that 1 degree is not equal to 1 millimeter. The best way is to plan your angle from the hinge point and then transpose this angle onto the proposed site of osteotomy on a true size X-ray, and then measure the base of this triangle, and that is the height of your osteotomy. The other way to do it is that you measure the length of the K wire which you have put up to the hinge point. It gives you the width of the proximal tibia at the site of the osteotomy, and then with your angle of correction, you apply it to the Hernigu's table, which is a mathematically calculated table for a particular angle of correction and a particular width of tibia at the site of osteotomy. You can choose the amount of osteotomy which you should open. That brings us to the second pitfall. We know that in open wedge osteotomy, there is an increase in the posterior tibial slope, and we should open more posteriorly than anteriorly to get a slope neutral correction, which is opening a trapezoidal osteotomy. This has been proven beyond doubt by a lot of landmark papers. But let's understand why. Now we are doing a correction in the coronal plane in most of the cases, and we are trying to prevent any kind of a change of angle or increase of angle in the sagittal plane. But remember, we are doing our osteotomy in a third plane. And when we open the osteotomy in this plane, this is bound to change the angles both in coronal as well as sagittal plane. In this study, they did a computer navigated high tibial osteotomy, and they showed that if the osteotomy was opened equally both anteriorly and posteriorly, it led to increase in the posterior slope. And mathematically, they proved that because of the geometry of the proximal tibia, which is triangular, the anterior opening of the osteotomy is closer to the hinge point than the posterior osteotomy. So mathematically, if we have to open less on the front as compared to posterior to get a slope neutral correction. So posterior opens more than the anterior. To execute this, we have to nicely release our superficial MCL underneath the pes also, so that we are able to open the posterior more. The posterior medial cortex is a very hard bone and it should be cut adequately. If we don't do that, then eventually we'll be opening more on the anterior side. The other important factor is the distraction point. You have to put your lamina spreader posterior medially in the hard cortical bone. And if you use a spacer plate, then you should put it as posterior as possible. If it goes anterior, it will lead to more opening on the anterior side. The other important factor is the hinge location. If you see this axial image, and if we drop a tangent to the medial surface of the fibula, then the zone lateral to this white line is the lateral zone. And our osteotomy should go just lateral to this line. And it should cut almost equally anteriorly and posteriorly. And then only the hinge is at the desired point. So the first image is the desired hinge location. But if we cut it obliquely, as you can see here, the anterior has been cut more than posterior. Then whatever releases I might do when I open this osteotomy, it's going to open more anterior than posterior. And if I do it reverse, then probably I'll have higher chances of doing a lateral hinge fracture. But if I do an inadequate or a short osteotomy, then the chances of sustaining a lateral hinge fracture are highest. Bone on the lateral side, and with a lamina spreader, when I try to jack up my osteotomy to shift the line of weight bearing laterally, that's when the lateral hinge gives away, either inferior to the proximal tibiofibular joint or it runs into the articular surface. Takeuchi has given a very good classification wherein if the osteotomy extends laterally, it is type 1, which is easily manageable, but type 2 and type 3 are potentially unstable situations, and they can lead to not only delayed union and non-union, but they can also lead to a loss of correction. At the same time, the osteotomy should not go very high right into the joint surface or should not be very low. If it is very low, then the proximal tibiofibular joint doesn't allow the osteotomy to open and it cracks. If your osteotomy was opening with its reasonable resistance but suddenly starts opening easily, it means we have probably broken the lateral hinge. And we identify it on table by seeing this springiness. If this springiness is present, it means the lateral hinge is intact. To prevent this, we have to keep at least 10 millimeter of lateral bone intact and do an osteotomy which is up to the planned hinge point and targeting the tip of the fibular head. Shorter osteotomy should be avoided by all means because it can lead to lateral hinge fracture, which can run into the joint. And always remember to do your osteotomy opening slowly and patiently. If you do the gradual plastic deformation, the hinge remains intact. The role of a hinge wire or a hinge screw has been shown in the recent literature, where they have proved that the hinge remains stable in axial and torsional planes if we use a hinge screw. But what if it has already happened? The type 1 osteotomy can be dealt with a compression screw through an angle stable implant, which if you are using that one, as you can see in this video. But if you're using some other implant, then a lateral tension band wire or a lateral staple should be used while giving an axial and valgus pressure to the limb. A type 2 type of a fracture can be dealt with a 3.5 plate or a type 3 with a lateral to medial CC screw. But by all means, by using all these tips and by keeping all the possible pitfalls in mind, it's better to avoid these complications so that we can give a good long-term result to our patients. Thank you very much.
Thank you very much, Dr. Pankaj. That was an excellent talk. This talk is now open for discussion. My first question to you is, do you use a hinge K-wire or a hinge screw in your practice? And if so, what are the technical tips of inserting it?
No, I haven't used it yet.
I'll ask this question to the other panelists. Do any of you use a hinge screw or a hinge K-wire? Raghbir?
Yeah, so I work with Christian Clay and Adrian Wilson, and Bhushan's trained through those guys too. We routinely use a hinge wire to protect the hinge, and that was so nicely presented by Dr. Pankaj that actually the papers demonstrate you can increase the strength and reduce the strain across the hinge 4-5-fold. You know, these are biomechanical studies. It makes a huge difference. So technical tip, you know, come proximal to your hinge, come lateral to your hinge, and go across the hinge point. I'm happy to share some pictures. I've got some on my drive. But it makes a massive difference. And if your hinge fails, I routinely use a nitinol staple, compression staple, or a variable pitched screw. like an AccuTrack screw. So those, yeah, but a hinge wire has been the single biggest thing that I've done that's really helped with my osteotomies.
So why don't you go ahead? If you have it at your ready disposal, we'd be happy to see the images of how you put the hinge wire. Please share
Okay. So while you guys keep on talking, I'll get the image up.
Right. So we'll have the next comment by Bhushan and then by Dr. Maheshwari.
So, I was quite impressed with Adrian Wilson, Raghbir, and Christian Klee's study on using the hinge pin for stopping the hinge fracture. And I use it routinely for any correction about 10 millimeters. I think I've just become lazy with time and I don't use it for smaller osteotomies. But any bigger osteotomy, I think it's better to stabilize with the hinge pin. And you can really play with the osteotomy much easily, bending the knee or straightening the knee with the laminar spreader and a hinge pin keeps it pretty stable. So it's a good idea to do it.
Yeah, over to you, Raghbir. We can see your screen.
So this is my screen. You can see there's a lateral hinge wire coming across. I put a wire in the proximal fragment, a wire in the distal fragment. This is what I use to lean on my laminar spreader so that I can leave my osteotomy gap free of any instruments or anything like that. I use, in the UK, we use femoral head allograft for to fill the gap. And this patient's had a previous ACL reconstruction, but this is my typical hinge wire. And you can see that before I've opened it, it would have been straight. And now that I've opened it, that there is a bend in the wire. So you can imagine all the stresses and strains going across that to distribute the pressure.
Have you ever had an instance of the wire breaking because of over-enthusiastic hinge opening? I mean, that would be a nightmare, really.
Not yet, but I'm sure I will. Not yet.
Dr. Maheshwari, you had a comment?
Yeah, Pankaj, we often have instances where the opening is, 14, 15. And very often after making the osteotomy, I struggle opening it. And I fear if I open it too forcefully, I will break the hinge. So what is the trick to be able to still open it, not break the hinge? How do you do when the correction is, say, something like 14, 15 mm?
So yeah, thanks for your question, sir. Usually in bigger corrections, the chances of fracturing the lateral hinge are higher. But having said that, if our osteotomy is going in the middle 1/3 of the fibular head, usually we under the CM image, if we are seeing the saw blade going right up to the middle 1/3, medial 1/3 of the fibular head, then usually we have cut enough. Mostly if your osteotomy is giving resistance, then probably the posterior cortex, the posterior lateral cortex needs to be cut a little bit more because that is the biggest resistance. If you have,
it has something to do with MCL release or
yes,
medial release.
Yeah, I mentioned about that. Superficial MCL under the pes must be adequately released because otherwise it will not allow the posterior opening to go more than anterior.
Yeah,
I agree on that.
Right. Thank you so much again, Dr. Pankaj. And we'll move on to the last talk before we take on the panel discussion. This is by Dr. Bhushan Sabnis. A very interesting topic, TCVO, the new kid on the block. This should be a very interesting listen.
Tibial condylar. Hello all. My name is Bhushan Sabnis. I'm a knee surgeon based in Mumbai, and today we are going to speak a bit about tibial condylar valgus osteotomy, also known as TCVO, which is like an LW to your normal high tibial osteotomy, and its role in correcting deformities in the knee for various arthritis. So we all know how your normal HTO works. We already heard a lot about this. So you do a cut at about 45 degrees from about 3.5 centimeters from the medial joint in the tibia, which goes all the way to the fibular head, and then you open the medial side of the tibia in a V shape, and then you put a plate on the medial side, as you see in this image, and you get a nice straight joint with a good fixation. Most of the patients do really well. Now, in this patient, the one on the left-hand side, it's a massive 16 millimeter correction. That's why there's a distal biplanar screw that you can see here, and they do really well. But you get patients where there is significant medial bone loss, as you can see on this patient, and there is a distinct type of tibial configuration because of progressive medial compartment arthritis. So 3 types have been described in terms of the shape of the proximal tibia: the flat type, the depression type, and the pagoda style. And this pagoda type of depression, as you can see, this patient is where a TCVO can be of use. Now, what is the reason for thinking about something else if your HTO works so well? Now, in patients who have significant medial bone loss, there is a concept known as tibial teeter-totter effect. That means despite correcting the deformity, the joint does not become congruent. And this has been recognized all the way in 1975 when this article was written by Kettelkamp and colleagues in JBJS. Now, also when you are getting higher correction, so again, in this patient, as you can see, the MPTA is about 74 and the deformity is quite severe, as you can see here. There is significant varus thrust, the tibial bone loss is making the knee quite unstable. And with that severe deformity such as this, if you just do an HTO, you might end up having a really bad oblique joint line. Now, in this patient, the deformity is exclusively in the tibia, not in the femur. So, a double level osteotomy is not an option in this patient. This paper was what changed outlook for most of osteotomy surgeons. This is by Kochiba from Japan, who talked about excellent results of TCVO for severe deformities. And I started doing TCVOs about 3 or 4 years back. A lot of papers have come out, a lot of articles have come out which describe the L-shaped osteotomy for advanced medial compartment arthritis, in which you can elevate the medial fragment or medial tibial plateau up and correct the deformity at the same time. For those of you who are interested in the role of TCVO and the need for TCVO, I would recommend reading this article by Teramoto from Fukushima about controversy of high tibial osteotomy. It describes it really well about how TCVO changes the biomechanics in a favorable way when there is a significant medial collapse and an early lateral subluxation. Now, this is one of my earlier cases where I just did a TCVO and got really good results out of it. So when do you consider TCVO as an operation for deformity correction in varus arthritis? Any patient with advanced OA and early subluxation of the knee will benefit. As I mentioned before, someone with excess medial tibial slope or excessive JCA, joint line convergence angle, the JLCA, are ideal candidates for TCVO. As against that, when you have excess varus deformity, a TCVO may not suffice. Of course, stiffness and inflammatory disease are contraindications for osteotomy otherwise as well. Now, again, for those of you who are interested, read this article. It's really well written about the indications and technique for TCVO and how you can decide based on the patient's scanogram whether a patient is suitable for TCVO or something more. Their device is very complex way of measuring angles. They're similar to the Miniachi technique. The correction angle is measured. That's called angle alpha. And the beta angle is a difference between the joint line convergence angle in stress view for varus and valgus multiplied by 1.5. I know it's quite complex, but they have devised a way of deciding that if the alpha angle is less than beta, you can have just a TCVO, and if the alpha angle is more than beta, then you can do a TCVO plus HTO. Reading this article, I sort of thought that most of the patients I see are either with severe deformity or significant bone loss, when I am not happy with my HTO corrections, and I should start combining these two techniques to get good results. And this is actually the only mention I could find in the literature where TCVO and HTO are combined. So let's look at a couple of cases and see if that makes sense to all of you. This gentleman is 52-year-old, has medial compartment significant varus arthritis. Now, it's the same patient that you saw in the earlier image. As you can see, the scanogram, there is early subluxation, there is significant medial slope in the tibia, and if I decide just to do a HTO, my correction will be about 21 millimeters opening wedge. It's quite a severe deformity correction. I'll end up lengthening him by about 1.5 centimeters. So this was someone who I feel is ideally suited for a TCVO plus minus HTO based on the severity of the correction. As I said before, if there is significant varus, these patients are better off with combining the two procedures together. That's the image after releasing the medial tissue intraoperatively. You have done a normal HTO, and despite opening it over 10-12 millimeters, you find that it's not giving you sufficient correction of deformity. So you make a cut in the tibia in vertical plane, going to the lateral tibial spine, making a L-shaped osteotomy. and then you fix it with a normal plate on the medial side. I think you need a sturdier plate, so I use a Tomofix plate in these patients. And then, as you can see, the deformity correction is quite significant. You elevated the tibial plateau perfectly, and the limb is neutral or slightly valgus, and these patients will be very happy. Now, this is an intraoperative video which shows the dual correction. So if you can see, I'm putting my spreader in the TCVO and in HTO. So I've done the double correction as just described here. Now, another case. Now, the medial tibial plateau fracture is actually called Schatzker 4 for a reason. Even if it's undisplaced, it's a severe variety and tends to collapse, as was happened, it did happen in this patient. He's only a 60-year-old gentleman with a medial collapse, and you can see the severity of the deformity here. Now, these are sort of the ideal patients who will benefit with a HTO, but I realize there's a lot of bone loss on the medial side as well. And if I just did a HTO, again, I would be going beyond 20 millimeters in terms of my correction. So I thought of an option of combining TCVO and HTO, and I'll explain it to you really well in this case. So as I've started using the hinge pin to protect my pins, especially when I'm worried about osteoporotic bones or when the deformity correction is quite high. So you've done a good 13 millimeter opening on the medial side, and the tibial plateau looks fairly leveled out. But look at that weight-bearing axis here. So it's still not up to the mark. So I'm not happy with that. So then you decide to go for a TCVO to combine with it. And once you open the TCVO, you realize that you have corrected the valgus deformity as well as you have achieved a good correction of the tibial plateau height as well. So this is the final picture. And as you can see, from where it was, you have actually achieved a stable tibial plateau with a good fixation and a stable fixation. And if you look at where the mucosis point was when you're assessing intraoperatively, from here is shifted to exactly center of the joint. I haven't overcorrected this gentleman because it didn't have any preoperative pre-injury arthritis in the knee. It was a traumatic event. So you can see the correction you have achieved in the patient. The leg is neutral and he is able to walk much better now. So in essence, planning is the key. A TCVO is indicated for subluxed knees and medial bone loss. And you can combine the two to get a severe varus correction. Now, if you look at this gentleman walking, his affected leg now looks to be neutral and his other leg looks to be slight varus, and he's actually indicated he wants to get the other leg fixed as well. So just to show it to you once again, if you look at the deformity before and if you look at the deformity after, it's got completely straight, and this is about 2.5 months from his surgery. So these patients are really happy that you can correct a severe deformity without a fixator, with a plate, and they're able to mobilize really well after that. Thank you.
Thank you very much, Dr. Bhushan. This was an excellent talk, and there's a good reason why this talk was kept after the complications talk, lest the viewers confuse the TCVO for an intraoperative complication passed under a new fancy name. So if I can be the devil's advocate, Dr. Bhushan, the first case that you showed, the mechanical axis fell outside the knee. Now, if we look at the learnings from the first talk, a mechanical axis falling outside the confines of the knee typically means a double level deformity, or at least we should look for a double level deformity. Did you do that check before doing this TCVO, or you straight away proceeded with the TCVO?
So I do planning for all my shows. So the deformity was completely in the tibia. So the femur and the LDFA was not significantly different from the other side. So the deformity entirely was in the tibia. And as I mentioned, if I just correct on the tibia, I was getting a very, very oblique joint line, which is something like a no-no for any of the osteotomies. And that's the whole purpose of thinking outside the box and thinking of TCVOs. I've done a few of these now, and they are quite hairy things to do. So you need to start worrying immediately because you're cutting anterior-posteriorly and you're going in the joint. But really happy patients with severe deformities have been corrected in one go. So I think it's the planning which is the key. If you realize that the deformity lies in the tibia and not in the femur, I think you can just get away with the TCVO plus HTO.
Correct. So if I can summarize the learnings, if the Mikulicz line falls outside the joint, think of a double level. But if you don't find a double level deformity, then think of complex procedures like the TCVO. Would I be correct in assuming that?
Absolutely. Yeah,
right. I invite questions and comments from other colleagues.
I have one question. Is it necessary to bone graft both these osteotomies, Bhushan, or if you wedge it slightly more, do you do any bone grafting, or do you put any tricalcium phosphate or any kind of these synthetic bones?
So I tend to bone graft most of my osteotomies over 1 millimeters in build. I use a allograft from Tata. So I use a femoral allograft for all my HTOs or TCVOs. I think it gives immediate stability to the osteotomy while the plate is being applied for healing. Of course, there is no evidence to show that healing is better with bone graft, but it just gives me good satisfaction that secured the osteotomy well. And especially the TCVO, I want to keep that gap open while I'm tightening the screws on the plate. So it makes sure my deformity, my correction doesn't suffer.
You prefer the bone bank?
Yeah.
Okay. Yeah.
Raghbir, you wanted to add something?
Yeah, just to say, I mean, Bhushan, that's an incredibly complicated surgery, and really amazed to see the images that you get from that. And those that are starting out, do not try this at home. It should be done in specialist hands. Bhushan, can you please tell me, how do you manage the tubercle? What's your sort of management of the extensor mechanism when you're doing that osteotomy?
Okay, so it's a proximal biplane osteotomy, like standard HTO, but the TCVO extends from just medial to the tibial tubercle all the way to the lateral spine as a criteria for the TCVO. So because you're done a proximal biplane, it gives you a good place to start your TCVO, and it is directed towards the lateral tibial spine. To begin with, you need to take a lateral view, pass a wire in that plane to confirm that you've got adequate depth, mark the depth onto the cut the cortex by putting a big hole on the back to protect your neurovascular structures. Go very slow. I used to take about 10 minutes just to do that cut. Be careful about it. But you realize that if you got a good Homan on the back, it's fairly safe to do that. And you spread it with your stacked Homans exactly the way you do a HTO.
Right.
Thank you.
Dinshaw, your comment, and Bhushan, can I request you to turn off your video? Your internet bandwidth seems to be a bit low. Your audio will be a little clearer if you turn off video.
Yeah. Sorry about that. Yeah.
It's an excellent lecture. One of the tricky points here is the correction when you're doing your TCVO. So when you're putting your screws in the proximal fragment and you've got an opening there, how do you make sure that that doesn't compress and you lose correction when you're putting in your proximal screws? What are your tips for that? Do you use a laminar spreader anteriorly? You really can't put in anything posteriorly to maintain that. And if you keep that laminar spreader anteriorly, does this then change the sort of correction anterior to posterior? So what are your tricks for that?
Tried putting the laminar spreader anteriorly, but found that the bone anteriorly is quite weak, and it just sprang open every time I did any movement of the knee joint. So I think bone grafting keeps it fairly stable. But the second point here is that you're using a locking screw, which is non-bicortical. So it is not common if you got a very weak thing such as bone graft also holding it. So you just need to be careful when you're locking the screw onto the plate. They're not inadvertently closing the osteotomy. But I haven't had trouble because I haven't used a bicortical screw. That's what I feel.
Thank you.
So do we have any more comments or questions for this extremely complex procedure? And I think Raghbir correctly summarized, do not try this at home. Do not even try this in the OR if you are not as experienced or as complex an osteotomy surgeon as Bhushan is. So we, I think, conclude the 4 excellent talks. I'd like to thank all the speakers for finishing on time and being generous with answering questions. And we now move on to the panel discussion, which will be taken over by Dr. Sachin Tapasvi, who quite recently conducted a wonderful panel discussion at the London Osteotomy course. We hope that he will really get the best out of the experts that we have here.
Thank you so much, and welcome again to this panel discussion. And it's a great pleasure to have all of you. I will be switching off my video and I'll be asking Ashok to remotely present, because there's no power from where I'm at home right now because of some unusual monsoon weather, and we're trying to present off a phone. Okay, next slide, Ashok. Thank you. So I think we start off with the first case. This is a 27-year-old male who is a soccer player, plays as a defender, right-footed. He had an injury to his left knee in about 5 years ago. About 3 weeks later, he had an ACL reconstruction done somewhere else. He re-injured his knee 4 years later. So he had a good 4.5 years of pain-free and good level sport. And following that, he complains of recurrent instability, pain, and inability to participate in sport. Next, please. So these are his imaging that you have in front of you. You have an ACL re-tear. You have tunnels which are enlarged to about 15 millimeters. You have a new medial meniscus tear, and there is tunnel widening as well. Next, please. This is what his alignment looks like. And Ashok, I'll just ask you to proceed with the animation so that we can draw all those lines. So next, now you have your weight bearing or your Mikulicz line, which is passing at the edge of the medial tibial plateau. You have the mechanical axis of the femur. You have the mechanical axis of the tibia, and that is the joint line. On measurements, your HKA is about 169.6 degrees. Your MPTA is almost about 80 degrees. Your LDFA is pretty normal, around 89 degrees. Ashok, please hit the next so that we can see the next transitions coming in. Next. Next. Sorry, go back, please. Yeah. And that's what we have with the posterior tibial slope of 17.3. So obviously, I think I would always recommend that all of us should include limb length alignment, both in the coronal and in the sagittal plane, as a part and parcel of evaluation of someone who has a failed ACL reconstruction, because it becomes all the more necessary to tackle these bony abnormalities whenever we are dealing with situations where we need to plan to do a revision ACL surgery. So next, please. So with this, I think I open discussion now as to whether this would be a single or a two-stage procedure, biplanar osteotomy or a uniplanar osteotomy, tips and tricks as to how you would manage the slope or if you need to manage it. Anybody who would like to use PSIs or fixators for doing their final fixation. So I'll start off with you, Dinshaw. If you can take us through your thought process with all these questions, with all these points that we need to look upon.
Okay, so great case, Sachin. So number one, I assume he's unstable and he's got deformity. So for me, this would be a single stage procedure where I'd do an ACL reconstruction and I'd do an osteotomy. So it would be very similar to what I just showed. I'm going to do the ACL first. I will measure the tunnels and see whether I can get away with a single stage revision ACL. But if in case the tunnels are too large and I need grafting for those tunnels, then that would be an indication for a two-stage. But it would be, as far as the osteotomy is concerned, it would be a biplanar osteotomy. I will correct the slope. I think leaving the 17-degree posterior tibial slope is going to cause the revision to fail also. and I fix it with a plate. So I'm going to correct it with the medial opening wedge, but I'm going to alter the slope and bring it to about 8 degrees from that 17 degrees.
Okay, Rags, are you going to be using PSI for this particular case, or you're happy to do it with conventional instruments that you have?
Yeah, so I think PSI has got a fantastic role to play in this. I think the textbook answer, Sachin, for this sort of case would be to consider doing a lateral closing wedge so that you can address the slope. We know that with the guys that I predominantly do medial opening wedge. That's the vast majority of what we do with our cases. But we know there's a risk of increasing the slope in this sort of situation. So for those of us who do medial opening wedge standard, a PSI is very useful to help manage the slope, because it's not just the cut that we make, the transverse cut, but you've got to think about what you do with your biplane osteotomy as well in order to accommodate the change in the slope as well. The tunnels were 15 millimeters. That's quite big. I would err on the side of caution and do a 2-stage procedure. I think with this patient, particularly with the drill holes that we're going to be putting in for our locking plate, it's really important to counsel this kind of patient. We know that with we don't know with elite athletes how well they do after osteotomy corrections and combined soft tissue procedures. So for those people, if you don't have access to PSI, one option would be to do a lateral closing wedge osteotomy staged, come back and do your ligament reconstruction. For those of us who do have PSI, I would still stick with my standard medial approach with a view to flattening off the slope and then coming back to do the ACL.
So when if at all you do a lateral closing wedge, how do you manipulate your slope?
So the lateral closing wedge completely lends itself to reducing the slope, whereas the medial opening wedge increases the slope. So you can make an eccentric cut when you're doing the lateral closing wedge, so the wedge that you take out, so that you take more from the front compared to the back in order to change the slope in that sense. Normally you don't have to do that, but given that you've got a slope of 17 degrees, that's significantly elevated. That's how I would do it.
Bhushan, question for you. What are the tips or tricks that you will suggest to try and maintain or get your desired post-operative slope the way you want it to be if you are not using a PSI?
I think the way I do this normally is I do one K-wire or a small shank screw which is parallel to the joint line in the proximal fragment, and another one which is parallel to the first pin in the distal fragment before I do the osteotomy, so that when I'm done, I will be aware of what my slope correction is. Of course, you're assessing it clinically when you're doing the osteotomy also. I will still do a medial opening wedge osteotomy. For some reason, I'm not very happy with lateral closing wedge osteotomy. So when I do a medial opening wedge osteotomy, you will need to complete the osteotomy. So you need to break the hinge completely all the way in the proximal tibiofibular joint, because unless you break the osteotomy completely, you may not be able to achieve a desired slope change. I will break the osteotomy, put a cancerous to hold it at the end. And what I normally do is, remember that anterior proximal biplane that you do under the patella tendon, you make a second biplane so that you have sufficient place for the proximal fragment to tilt. So when you're taking the first biplane such as this, you make a second biplane next to that under the patella tendon. So you take a really small 1 millimeter wedge off from the proximal biplane, and that gives sufficient space for the proximal fragment to tilt when you change the slope. And you can use that as a bone graft wherever you want. Of course, you make a trapezoidal gap in the osteotomy, but that trapezoid has to be much wider posterior as compared to distal. But you need to assess the slope based on your correction. There's a limit to how much you can correct when you're doing a medial opening wedge osteotomy, because you don't want to push an athlete into the. So I would suggest just at 50%, so neutral attitude of the limb and ACL reconstruction.
Okay, fine. Ashok, next slide, please. So, a 10-degree increase in slope is going to decrease your anterior tibial translation by about 6 millimeters. And that's why, addressing the slope becomes also very important in these patients. Next, please. The PSI, I think, has been a great tool for all of us. And for those who have not used PSIs and who are planning to take on complex cases, one of the good things about the PSI is that you can actually have your hinge at the correct position, which many a times will not require you to actually do a biplanar osteotomy. Next, please. So what I ended up is to do a single stage ACL revision using his ipsilateral quad tendon graft. I did add a modified lamelle for him and did a concomitant medial meniscus repair as well, and did a biplanar. You'll have to go back. Yeah, I did a biplanar medial opening wedge and decreased the slope. And his final measurements did show that his HKA was 181 degrees, MPTA was 89, LVFA stayed the same, and we decreased the slope from 17 to 9.8. We'll go on to the next case. So the next case is a 34-year-old female who's a runner. She runs about 20 kilometers every week. She injured her left knee about 2 years ago whilst running. She stumbled and she fell down. 6 months later, she had ACL reconstruction using a hamstrings ipsilateral graft. She does complain of increasing pain and difficulty in sports with buckling. She has had no re-tears or re-trauma. And when I evaluated her, which is almost about 14 months following her index procedure, she had a grade 3 lax ACL with a grade 2 pivot and normal coronal plane alignment. So obviously we have here that her ACL has failed. Again, to try and emphasize the role of doing weight-bearing monopedal stance X-rays. Next, please. She has a high slope with anterior subluxation of the tibia. Next. Next. Okay, you'll have to go back one slide. Yeah, okay, perfect. So essentially, I'm not going to take you through all the other details. The question here, Pankaj, for you is that how will you tackle such a patient who has a ruptured ACL, has got a high slope, but unfortunately those measurements for the slope are not coming up. Her slope is about 14 degrees. So Pankaj, in your hands, how will you tackle this patient who obviously has an unstable knee with a high posterior tibial slope?
So do we have any coronal image of?
So I've just left it out because we're almost about 85 minutes into the webinar now, and I've just taken out all of them. So coronal alignment is neutral, meniscus is neutral, everything else is normal. You're dealing with a lax ACL, a grade 2 pivot, no hyperlaxity, and a high tibial slope of 16. Are you only going to do an ACL revision, or are you going to correct the slope simultaneously as well? And she is a weekend runner. So she likes to run about 20 kilometers per week.
Right. So probably, sir, I'll be offering a slope correction osteotomy to begin with in the stage 1 and see how she responds to it and how much instability remains later on. And if she complains of instability, then later on I'll go in and probably do ACL reconstruction.
Dinshaw, do you feel an osteotomy alone will solve her problem? Or a ligament reconstruction alone will solve her problem? Or does she need both?
If she is unstable and clinically she's got a grade 3 with a pivot positive, it's highly unlikely that just the slope correction is going to give her the stability she desires. But if the coronal plane alignment is normal, I'm not going to be doing a standard medial opening wedge osteotomy. I'm going to be doing a slope correction osteotomy. And in those situations, I normally will not do an ACL at the same stage. So if she does have a significant, so I'm going to, of course, calculate the posterior tibial slope. It's increased. We can see the anterior tibial translation here. I would do just a plain slope correction osteotomy first. We know that this itself affords a significant amount of stability to the knee. And if I find that the patient is no longer unstable, she's just a runner, then I might just leave it at that and not go ahead with ACL reconstruction unless she needs it. If she needs it, you could always do it at the second stage.
Bhushan, any difference of opinion? Rags, any difference of opinion, or all are on the same page?
I think I agree. So you might be surprised by the power of osteotomy that she may not need a ACL reconstruction. Of course, the choice would be different for someone who's an athlete with a contact sports involvement.
Yeah, nothing much more to add, really. I work with Ronald van Heerwaarden on a lot of these cases. We're looking at our series, and a lot of them don't need the ligament reconstruction. If they do, these guys heal up very quickly. And at the time that we're taking the metal work out, so when we're taking the staples out, we'll do the ligament reconstruction at the same stage.
Okay. Next slide, Ashok. Yeah, next. So what usually happens is that when you have a high slope with dysfunctional ACL, you get anterior tibial translation, and you can do this isolated slope correction at 3 locations. Next, Ashok. You can either do it completely next above the tibial tubercle by removing a wedge next, and then going ahead, closing it and fixing it with next a staple or a screw next. And this, as has been rightly pointed out by our expert panelists, brings it back on next. I have been a bit concerned to do this only in the metaphyseal area because of the small stature of bone that a lot of people in the Indian subcontinent have. Next, the next described technique is to do it sort of midway, which is to make a small biplanar cut, and next remove a wedge and then close this up, fix this with a staple, and this restores it. Next, please. When we're dealing with larger corrections or next smaller tibias, the other very well published and documented technique that we have is to first do a tibial tubercle osteotomy, flip out the tibial tubercle, then go ahead, perform your slope correction, either closing or opening, and then fix the osteotomy with the staple, and then put back the tibial tubercle and fix it with a couple of screws, which acts, next please, which acts like somewhat of a biological plate. So given these 3 methods, amongst all 3-4 of you who are doing these closing wedge osteotomies, very quickly, Bhushan, Rags, Dinshaw, and Pankaj, which osteotomy do you prefer? Do you prefer it completely above the tubercle at the level, or do you do a tibial tubercle osteotomy and do it as I've shown in the third example?
Third example.
What about you, Rags?
I go for the third example. That's allows you to adjust the patella height if you need to do anything. Great access, gives you lots of ability to do a big correction if you need to, as well as the small ones, of course. But I go with the third option.
Sure.
Yes, absolutely. I think the third option is much, much better. You have the whole thing open for you. It's an easier procedure to do, and then you use this as a biological plate and then fix it. So I think it also stabilizes your osteotomy above and below. So I think it's for me at least, it's the third option.
Third option for me also.
Okay, Pankaj. Next slide, please. So that's what I ended up doing. Again, did a tibial tubercle osteotomy. The hinge point is at the PCL insertion. Next, please. And this is the final result. I actually did a concomitant revision ACL for her because she didn't want to come back again. And we did the biological plate technique with a closing wedge. Ashok, I'll please ask you to go through with all the various little builds that we've put in. Next, please. And show us the next case. Raju, should I go in for the next case or shall I stop?
Please do one more case, and then there are some audience questions also which we would like the panel to answer.
Okay, so I think we'll skip this case. I'll get Ashok to go.
What we can do, Sachin, quickly just go through this case. You can just show what you did in a minute without quizzing anybody.
Okay, so this is just opposite example. She's a lady who had an injury about 12 years ago and had a lax PCL. Next, this was her alignment. You can see that she's had some anterior tibial physeal arrest. Next, with reversal of slope, as what you can see here. Her slope here is actually a negative -3. Next, Ashok. Thank you. And next, and that's what her limb looks like. She goes into complete hyperextension. Next, Ashok. And this is again a very good indication to do an anterior opening wedge osteotomy with the same technique as what we discussed before. Next. And that is a limb at the end of the procedure. Next. And that is how her slope looks like. Next. And you can see there. Next. We've used autograft. Next. And her slope has been restored to about, I think, +6 degrees. So with this, the tibia completely reduces underneath the femur, and the PCL lot seems to be more happier than the ACL. They just don't want any ligament reconstruction whatsoever. Next, we'll go to the last case. He's a 49-year-old gentleman who sort of stays in the rural part of our country. He had a motor vehicle accident last year, just before the pandemic started, and there was lockdown all across the country. Of course, with the current guidelines and the knowledge available then, he was advised by his treating orthopedic surgeon locally to just stay put in a plaster cast and was not offered any surgical treatment. And he had essentially a bicondylar upper and tibia fracture. And he presented to me about 2 months ago with shortening limb and pain. Next. So that's how it is. And what you can see here is that he has a thrust deformity. Next. And his MPTA is down to almost about 81 degrees. Next. Quite important in these patients to also look at a 3D CT scan for planning. And what one sees here is essentially depression, fracture of the medial tibial plateau, quite similar to what Bhushan did show in his case, but there is a tilt as well, along with alteration of slope and rotation of the fragment, along with a second fragment, which has also resulted in a lateral tibial condyle, which has got depressed with the presence of an increased slope. So Rax, how would you tackle this? Would you do an osteotomy? What level? How would you, what sort of guides will you use? Or would you just say, let me put in the knee replacement and forget about it?
Yeah, I think the final option doesn't sound like a great option for this poor chap. He's working in a rural environment in agriculture. They're quite manual. I think this is a really good case for the PSI osteotomy, Sachin. So, getting the deformity correlated on a CT scan, making sure that you know exactly where you need to make your cuts. It makes the operation much, much easier. But obviously, these aren't always available to us, in which case you can do the similar technique to what Bhushan was showing us earlier with elevating the hemiplateau. But I think PSI would be perfect for this.
Bhushan, would you do a TCVO for this patient, or what would you do?
I think I would essentially do a TCVO, which is intra-articular plus extra-articular correction. Same way, I think the fracture is almost healed. So breaking the fracture again doesn't make sense to me. So I'll make a new TCVO and elevate. The only change I will do is I'll go more anteriorly, elevate the tibial tubercle as a separate fragment, as you showed for the slope changing osteotomy, and that posterior lateral depressed fragment, I will see if I can push it up using a punch and graft it as well, if it's possible. Quite a few times you'll be surprised that they are elevatable, if I use that word, by punching it and bone grafting it. So you might be able to undo the jigsaw puzzle and get it into a right situation.
Pankaj, any thoughts on this particular case?
Just would like to re-emphasize the importance of getting a 3D CT scan if we are planning to elevate that depressed intra-articular fragment, because we need to really locate that fragment, that particular spot very carefully if we attempt to lift it up. Besides that, single condylar lifting osteotomy, that's what I would do.
Dinshaw, any difference of opinion?
Sorry, I think this is quite a complex case. You need to see two aspects here. You need to get good mechanical alignment. I think that's going to be key for a good result at the end. But also what his joint congruity is like. I think that's going to be the second aspect that you need to study on the CT scan. You certainly don't want to do a medial opening wedge high tibial osteotomy and find that the lateral compartment itself is deficient. So I think you need to assess that before you do it. If I found that the joint congruity is good, I would do a standard medial opening wedge high tibial osteotomy. But if I found that that was not good, then I think a TCVO would be a better option.
Well, just to give you some more piece of information, for sake of time, I'm not showing the MR scans. He does have chondral damage on the medial compartment as well. So are you then inclined to correct him to neutral or just beyond neutral then? Considering that he has got some pre-existing osteoarthritis, would that change your plan in any way?
Pre-existing arthritis medially or laterally?
Medially.
So I think that's the thing. How good is the lateral compartment? That's going to be critical. If we're going to shift the weight to the lateral compartment and that lateral compartment is not good enough to take that excessive load, which is going to be 70%, I think that osteotomy is going to fail. He's going to become painful laterally. So I think there are many aspects here to consider, but at the end of the day, getting good alignment is going to help him, and trying to get that joint line back to plane is going to be useful. If he had a good lateral compartment, I would tend to make him more into valgus.
He does have a good lateral compartment. Next slide. And this is what we ended up doing. I actually elevated his posterior fragment as a separate osteotomy, since there was significant depression on the CT scan. Fixed it first with the help of a plate, and then did a medial opening wedge and bone grafted both of them. And intentionally, I put him in bit of valgus at the near about the Fujisawa point, because I was concerned about his chondral damage that he had before he presented to me on the medial side. So I think you can stop the presentation now, Ashok. Thank you so much for looking at 4 cases. I hope we were able to get out all the different nuances and the different possibilities that are possible using a high tibial osteotomy, and hand it over to Dr. Parag and Dr. Raju for the last concluding session.
Thank you so much, Dr. Sachin. It was a very wonderful selection of cases, and I'd like to thank all the panelists for their insightful answers. We'll just take very quick 1 or 2 audience questions that have come in the chat box for the respective speakers. Bhushan, there is a question, or rather a comment for you, and it's a very interesting comment made by Dr. Milind Chaudhary, who we know is quite reputed in deformity correction. He says that he's been doing TCVO for quite a while now, and quite contrary to what your view is, he feels that first the intra-articular osteotomy should be done, and then if any need of extra-articular osteotomy is there, that should be performed. So his take is that a TCVO is a pure intra-articular deformity correction exercise, and his sequence of doing the operation would be a TCVO first, then a HTO if required. What are your comments on that?
No, I think that's absolutely valid point. If you are sort of decided that the main problem is the medial plateau depression with less varus deformity, then I think TCVO alone would suffice. Then HTO may not be required as such. But when you are aware that the Miculus point is less than 0, that means the weight bearing axis is falling outside the joint, then you are going to be caught while you're doing the TCVO. You'll realize after doing TCVO that you're not able to correct the deformity satisfactorily, and then you need to add HTO. What I find is that it's easier for a simple surgeon like me to do a standard HTO and then add a TCVO rather than going in the reverse direction. Milind is a very gifted surgeon. I think it's easy for him to do these things. But I think for following a straightforward approach, just do a HTO and then add TCVO as required is my go-to option.
Thank you. But the last I recall, your designation said complex knee surgeon. So maybe Milind is more complex knee surgeon.
Yeah, he's a super complex knee surgeon.
Dinshaw, a question for you. The nuclear plate that you showed in your presentation, one of our delegates, Dr. Gupta, wants to know that he has faced this problem of unusual anteromedial prominence of the plate in a few cases, especially in females with a short tibia, and he wants to know if there's any way to avoid it.
So I think you need to keep the plate. You need to make sure that your plate is sitting back. You can't mold that aspect of the plate. Though you get a special molder that you can mold at the metaphyseal aspect, you can't mold this top part and try and make that, because then you're locking, your polyaxial screw will not lock. I suspect all you need to do is make sure that it's placed a little more posteriorly on the tibia so that the anterior part is not too prominent.
Correct. We have one question which anybody in the panel is welcome to take. Dr. Sheikh Ahmed wants to know how to proceed in an established case of secondary osteoarthritis after ACL reconstruction. So an ACL has been done a few years back, and now the patient comes to you with secondary osteoarthritis. Is osteotomy useful in such cases? So post ACL reconstruction osteoarthritis is a high tibial osteotomy. Does it work as well? Rax, would you like to take this?
Yeah, so I mean, it all depends on the deformity. So if they have got the various alignments, so planning, making sure that long leg alignment views demonstrate, typically they've gone into varus. A lot of the athletes who've developed ACL, who've had an ACL rupture, in my practice need medial opening wedge osteotomy, but I've had no issues with that. So osteotomy works fine. Make sure the slope is to get coronal as well as sagittal alignment views before you proceed, in case you need to do anything to the slope. But I've encountered no issues with doing that.
Right. Dinshaw, you want to make a comment?
Raju, I think a lot of these patients that we see who are either chronic ACL deficient knees who've not had instability and come to you just with medial compartment OA, or patients who've had ACL reconstructions which have failed, but who for whatever reason are not unstable and come to you with medial compartment OA. I think in these scenarios, if they're not unstable, all you need is a medial opening wedge high tibial osteotomy. You don't need to add a concomitant ACL reconstruction if there's no instability. So you just do a simple standard medial opening wedge high tibial osteotomy. Now, the second thing you need to look for is this truly a unicompartmental or a monocompartmental osteoarthritis, or has this gone into the patellofemoral joint also? And so that's not a radiological assessment. I think that's a clinical assessment. If these patients also have significant patellofemoral OA that's symptomatic, then I think your role of the medial opening wedge high tibial osteotomy has to be limited. You need to then consider something else.
Right. So I'll wrap this up and I'll request Dr. Parag for his comments and vote of thanks to close this particular meeting. Thanks once again from my end.
Yeah, thanks, Raju. We have just two quick questions which have come in my chat box. Some basic questions which we'll just get through. I know we're a little time, but a few minutes more. So the first question is, whenever you're doing an osteotomy, which does not involve an intra-articular procedure like an ACL or something else, is it mandatory, and do all of you do a quick diagnostic arthroscopy before proceeding with your high tibial osteotomy? It's a very basic question I would ask all the panelists. Dr. Raghbir, if you can answer.
Yeah, so when I was training, we routinely used to do an arthroscopy, and then since I've been working with Dr. Christian Clay, we've never done one. And the reason being, it reduces the amount of pain and swelling the patients have after surgery. The decision has normally been made based on MRI scan and clinical evaluation. Of course, if there's a displaced meniscal flap that needs to be remedied with an arthroscopy, of course we will do it. But as a routine, I do no longer do an arthroscopy at the same time.
Dinshaw?
I do it routinely. So routinely, I would start off with that arthroscopy, and I'm looking for 2 or 3 things, exactly as I showed in that video. Check the lateral compartment, look whether that lateral compartment cartilage and meniscus is good enough for the increased loads it's going to be put to. You've already assessed that on the MRI, but would be worthwhile to do a diagnostic arthroscopy too. On the medial side, look for any loose bodies, any flap. And if you do find a grade 4 chondral defect, you may actually opt to do a minor chondroplasty or a bone marrow stimulation there too.
And how many times has this diagnostic arthroscopy changed your decision than what you were thinking pre-operatively, what you had in mind? In how many cases, or a percentage if you can give, has changed your pre-op decision?
Very good question. And that's exactly what Raghbir mentioned. So if you really studied your MRI well, it's very, very rare that you're going to change your decision intra-op, that this is the patient that I'm going to do an arthroscopy on. I can remember maybe one in my entire career where I felt, look, I think this lateral compartment is not good enough. There's a significant chondral loss there, softening there, and where I've done just an arthroscopic debridement and said, look, I'm not going to be doing an osteotomy for this patient. I can think of only one. So it's not very common.
Okay. Pankaj, do you do a routine scopy?
Not for every patient, sir. Only if my patient has had some mechanical symptom of the recent onset, only then I will go in for arthroscopy.
Sachin?
I do a scope because I just feel, if you have the tool, why not use it? Sometimes you do find, certain loose chondral flaps or meniscal flaps, which need to be tackled at the same time. And I probably feel that I'm doing a complete job, both intra and extra-articular, by doing an arthroscopy as well.
Yeah, Bhushan, can you just give concluding, because we have two people who do all the time, two people who don't do all the time. Maybe you can just sum up very quickly, what would be the message?
As a routine, so as a routine, I don't think it's essential to do an arthroscopy patient if you have looked at the MRI properly. But what I found is that they have a bit more pain as compared to standard HTO if you had an arthroscopy, even if it's just diagnososcopy also. So inside the joint, let's say meniscal tear or something, some chondral pathology that needs some intervention. But as a routine, I generally avoid doing arthroscopy unless there is a specific indication.
Raju, any quick thoughts from your side?
So I would like to do a scope. It just takes a couple of minutes, and it does give you a fair measure of security as to how the joint looks in 3 dimensions. So I would always like to do a scope before a osteotomy.
Yeah. So same is my thinking. I'm in line with Dinshaw, Raju, and Sachin. It just takes a few minutes, and sometimes it's better to do a quick scope. Yes, Dinshaw. Unmute. Dinshaw, you'll have to unmute.
Sorry. So if you find that you've got a medial compartment OA and you've got a large osteophyte on the medial femoral condyle and you're doing an HTO, do you think it's important to get that osteophyte out? And would you do that arthroscopically? Or if you're doing it open and you're not doing an arthroscopy, would you open the joint and do that? I just want to know the view of the role of that osteophyte on the medial femoral condyle, medially.
Dr. Raghbir, would you like to take that question? The medial osteophyte, would you like to remove it? Would you scope it? Would you open it and remove it?
Yeah, so I've not had any problems with that, Dinshaw, at all that I've encountered. The part of the procedure is getting rid of that soft tissue tension in the medial collateral ligament, and doing. We know that if you adequately release the MCL, the tension around that envelope it also reduces. So, to be honest, I've not had any problems with the medial osteophyte, but I can see the value in doing that. But I would say when you are doing these, make sure you do an adequate MCL release so that pressure you get from the medial osteophytes and the medial compartment pressures is reduced.
Okay, thanks. One last question and then we wind up the session. This question is for Raghbir and Sachin also. Again, a basic question, but many people have written that they want to know a little more about the PSI. How do you procure it? How do you get one in India? How much does it cost? So I'll let Raghbir answer first, its value, and does one need to have it in this current age and time? And then I'll let Sachin also give his views. Raghbir.
So I very rarely use the PSI, but it is very, very valuable in particularly the post-traumatic deformities. We've had previous incisions, previous osteotomies as well. So in a revision situation, it can be very useful when you're wanting to adjust the slope. The way to acquire it, I use the new clip system. So they have a protocol for CT scans going from the hip, knee, down to the foot and ankle joint. It's not very expensive. It's a 3D printed jig that comes in a package. It gives you all the predefined screws. It gives you all so you don't have to measure the screws. It tells you exactly what you need to put in, where to put the saw cuts. So in a lot of instances, it's a much easier procedure with this. So, but the only downside advantage that I have found is that you have to make a larger incision to accommodate the jig. But I don't know the cost in India, so maybe Sachin can allude to that.
Because a few years ago, it was very popular with knee replacements, but over a period of time, people have moved away from it. I would be happy to hear Sachin's views on the PSI.
PSI typically requires a downtime of almost about 2 or 3 weeks. So you need to plan your case properly. I will use it in certain situations where you need to do concomitant surgery where you are likely to encounter or you want to decrease the incidence of having too many tunnels. I've used it maybe about 5 times up till now with a combined ACL, with a combined PCL. I've used it once with a combined ACL, PCL, along with an osteotomy, and used it once with a combined ACL, meniscus allograft, and osteotomy. So in all those difficult cases where you probably need to try and decrease your stress levels, it becomes a useful tool to have all the screw positions so that you don't have to take out screws, revise them. You get coalition, and that leads to problems.
Thank you.
Dr. Sachin, there's one question for you from my end. I'm sorry to interrupt. Which make of staples do you use to fix these slope correcting osteotomies? Are they the same staples that we use in ligament reconstruction, or are they different?
These I've got them made, a copy of the Stryker staples, were the ones which Stryker manufactured. So these are made by the biotech company. I got them to make them for me, the same specifications.
Okay. So, well, if no other comments or no other questions, we'll close. It's been an excellent session. A lot of knowledge in the last 1 hour, 45 minutes that we've spent. And I'm sure all the delegates have definitely benefited from it. On behalf of Ashok Sham, I want to thank all the speakers, especially Dr. Raghbir. Thanks for joining in. Even though being a Sunday, we appreciate you tuning in. And I also want to compliment you for the London osteotomy course. It was awesome. I was there in and out. I was listening to some of the talks. It was really well conducted. And Raghbir, we thank you.
Thank you for having me.
Joining in today.
Thank you.
Also, all the other speakers who are our own ski founder members, Dinshaw, was really good. Bhushan, excellent talk, and thanks for introducing us to Raghbir and making sure he's there today. Thanks for that. Pankaj, your talk on complications was excellent. And Sachin, those cases were really nice. We could have gone on for another half an hour, but very crisply you brought out 4 scenarios very well, and thanks for that. And Raju, the session was very well conducted. Before we end, I want to thank Ashok Sham, without whose help we would not have been able to broadcast this through Ortho TV. At the moment, I can see about 1,320 people, who have been in and out. And thanks, Ashok, for this. We appreciate your help through the global Ortho TV and for having broadcasted this to all your delegates. With this, we'll close the session. Raju, excellent. Good job. Thank you, everybody. And till we have the joint preservation seminar part 2, see you. Bye-bye.
Thank you.